So the next poster is focused on nurse retention and the COVID-19 pandemic, a review of Ontario nurse retention rates between 2013 and 2021.
Nurses experienced increased levels of stress and burnout during COVID-19, leading to concerns of a major nursing exodus. However, there is no research on realized nurse attrition in Ontario or any jurisdiction in Canada. We measure nurse attrition rates in Ontario and compare pre-pandemic trends 2014 to 2019 to the first 2 years of the pandemic, 2020 and 2021. We distinguish between permanent and temporary exits, determine the proportion who returned to the profession within 3 years, and the probability of attrition by age group. We use an Ontario Ministry of Health dataset which derives from regulatory college registration data. We focus on registered nurses, RNs, and registered practical nurses, RPNs. Our temporary attrition category includes nurses who register active but are without employment, while our permanent attrition category includes nurses who register inactive or do not register. These nurses are unable to practice. Overall, we do not find a significant increase in Ontario RN and RPN attrition rates during 2020 and 2021. In fact, figures 1A and 1B show for both sets of nurses, total attrition, the gray dotted line, has exhibited a slight upward trend since 2018. Attrition derives primarily from nurses registering active without employment, the dark blue line in figures 1A and B. As displayed in Table 1, these nurses are significantly more likely to return to the profession within 3 years, at over 50% for RNs and 60% for RPNs. Lastly, from figures 2A and B, we find the probability of attrition among younger RNs, the dashed blue and orange columns, decreased in 2020 and modestly increased in 2021. The probability of registering inactive or not registering is highest among RN 60+, the dark blue column. Similar results, though not shown, are found for RPNs. To conclude, we do not find evidence of a significant increase in nurse attrition during 2020 and 2021. However, the pandemic may have a lagged effect, and policymakers should continue to monitor nurse attrition.
Okay, great. Thanks very much. Kind of counterintuitive, but perhaps as they said, by 2022 or 2023, we may have seen some of that attrition start to emerge more, or maybe that was something that was played up in the media, but I expect not. Okay, let's keep going. So understanding health workforce demand during the COVID-19 pandemic and beyond, using a network of policymakers and industry employers. Hearing from Benjamin Stubbs and Susan Skillman.
Hi, yes, this is Ben Stubbs. This is highlighting some work that has been active since 2016 called the Health Workforce Sentinel Network in Washington State in the United States. And this is an effort to survey employers across the entire state every 6 months to understand their health workforce needs. So when the COVID pandemic hit, we leveraged this ongoing activity to understand more about employer needs during the COVID pandemic. And we met with a series of stakeholders that had been, we'd established before through this ongoing work, and identified with them key topics that they were interested in learning more about. And through this work, we were able to track changes in employer needs and demand throughout the pandemic, and are continuing this effort after the pandemic. In the center of the slide there, you see a case study looking at skilled nursing facilities where we can see how trends changed over time in this healthcare sector. Before the pandemic, most employers were talking about wages and burnout as problems, and there's some quotes there to illustrate that. Early on in the pandemic, the top needs were around PPE and keeping residents and workers safe. As the pandemic continued, there was more news about burnout and turnover being problems. And then late in the pandemic, spring and fall 2022, there were efforts to focus on recruitment and retention strategies and attracting people back to the workforce that may have left. So in summary, this has been a valuable tool that was established before the pandemic, and we are continuing to use afterward to identify key topics that are affecting health workforce demand from employers. And we hope to continue this into the future. There's a link there to get more information and encourage you to visit the website and learn more. Thank you.
Thanks very much, Ben. Picking up that theme around sometimes maybe attrition rates haven't changed, but if people are moving from the public to the private sector, that can also be something going on behind the scenes. So next up, we have the migrant wage gap among pharmacists in Canada. Neeru Gupta.
Hello, and thank you for listening to our research presentation on the migrant wage gap among pharmacists in Canada. We used data from the Canadian Population Census to investigate imbalances and disparities in health labor outcomes among professionals in pharmacy in comparison with other sectors of the allied healthcare workforce, critical contributors to the healthcare system, but often understudied. Perhaps not surprisingly, as this reflects the overall trend in the healthcare workforce, pharmacists were predominantly female and feminizing over time. By 2016, 62% of active pharmacists aged 25 to 54 were women. Moreover, the allied healthcare professional workforce is increasingly represented by adult migrants, that is, those who migrated to Canada at age 20 or above, reflecting opportunities for advanced health professional training and access to the health professional workforce. We found that after adjusting for gender, educational status, age, and other human and social capital variables, pharmacists who had migrated to Canada in adulthood earned 22% less than their native-born or other pharmacists who immigrated to Canada before the age of access to higher education. This migrant wage gap was a little bit wider than that observed among dentists, but somewhat narrower than that observed among physical and occupational therapists. Our research shows that policy and programs are needed for migrant health workers to achieve full economic inclusion, and particularly the essential allied health workforce, which employs significant numbers of skilled immigrants and especially women.
Great. Thank you so much. Super interesting to see, especially given the control for the, what does it say, adjusting for other characteristics. That's the part that I really stands out for me, that there's a, even adjusting for those other characteristics, we still see this gap. So next up, we have the part of the solution, developing recommendations and tools to improve the pathway for IEHP using an intersectoral community practice model.
Thank you very much. Hi everyone, I'm Kat Goodfellow, the Research Coordinator for the National Newcomer Navigation Network, or N4. Today I'm reporting to you on how we developed 2 recommendation reports to improve pathways for internationally educated nurses and physicians. So in 2022, we were tasked by our funder, IRCC, to provide support around getting foreign-trained doctors and nurses to practice in Canada. We began with a series of 74 stakeholder discussions, expanding our network, and learning about the critical situation on the ground. I did some qualitative analysis of that data and developed a report about the current state entitled A Missing Part of Me. We then moved into developing recommendations to improve that state. The work was carried out with 2 intersectoral working groups attached to our community of practice, our CIP. Our CIP allows us to really quickly put together working groups to take critical pieces of work off the side of the desk of professionals. They are time limited, they have a clear deliverable attached, and N4 provides the research admin and project management support. Our IEN and ITP groups met quarterly for a year, and we supplemented their work by validating the results through 2 lived experience committees. Our reports are all available on the website. You can see them in the bar to the right there. Since their publication in April 2023, we've been reaching out to key stakeholders, working with them to understand and implement recommendations, and connecting them to other people doing the same work. We've also developed some additional tools, which include scorecards, so provincial governments can see how they stack up, briefing notes, and a whole suite of employer-focused tools that are designed to support employers in recruiting and retaining IEHPs. If you're interested in this work, which is ongoing, or in issues of health and social service equity for newcomers in general, visit newcomernavigation.ca. You can sign up for free and access all of our tools and webinars there. Thank you so much.
Okay, thanks very much. Really interesting to reflect on the mix of engagement and data-driven research, right? That both are so important. So we do have a couple of minutes for questions, either from the online or the in-person audience before we go to the next lightning round. Ivy?
I'm hoping that Alyssa is still on. So I just wanted to ask about the findings in regards to nurse retention. What might be some of the limitations of the data set that found these, where you found something really quite unusual? So what might be explaining that, or is it just that the dialogue in the media is not really evidence-based? So just want to pass that back to you.
Is Alyssa online to field that question?
So I would say the main limitation is that we only have access up to 2021 data. And my kind of thought is that if we see retention, it's going to be delayed. I feel like a lot of nurses stayed at work during like the thick of the pandemic in 2020 and 2021. So I suspect a lot of the changes in retention will happen post-pandemic. I don't know if that answers your question.
Yeah, no, that's great. And were you able to look at the kind of pull into the private sector, or was your data blind to whether people were working for a publicly or privately financed employer?
So the data set derives from the Ontario College of Nurses registration data. So it's on all nurses in Ontario that are registered and that have to be registered with the College of Nurses to practice. So I am able to see if nurses work at agencies, if that's what you're.
Yeah, no, I was just, you didn't explore that, but it sounds like you have the data.
So
you could take a look. Okay.
Yeah.
That'd be great to see. Yeah.
Yeah.
Are there any other questions?
Question online. I'm not sure if you can hear me. There's a question here about what type of stakeholders are the 74 mentioned for migrant workforce pathways?
Hi, yes, I think that's our presentation. Thank you for the question. So these were anyone working along the pathway from immigration to optimal employment in the IEN and IMG licensure space. So educational institutions, bridging programs, anyone working in credential assessment and accreditation, regulators, licensing bodies, employers, and we also had people with lived experience as IHWs, and that was both people who were trying to get into the field, people who had successfully gotten into the field, and people who were totally trained but had actually been working in other professions because they couldn't become licensed. So, and in addition to that, I believe we spoke to some provincial governments as well. So it was coast to coast, with the exception of Quebec and the territories, which our funding does not cover.
Okay, super. I think we should move on to lightning round part 2. So, which is focused on workforce data and planning and workload and care processes. So we'll start with a modern data architecture for health workforce planning in Canada with a presentation from Dax. Come on up. Yeah, absolutely.
All right. Hi again, everyone. So this work is on behalf of Sarah and myself. And through the pandemic, we've certainly seen some of the vulnerabilities of our Canadian health system. And part of that is in terms of data, health data in particular, how we can interpret it, analyze it, how it's reported, and how it can be used. Part of that is perhaps because there's no common overlying, vision or data architecture in order to kind of allow a lot of the work that's done in silo to be concerted. And so what we've created is a kind of a national data architecture for health workforce planning. So I'll take you through the figure. I was hoping it would look a little bit bigger sideways, but it starts at the top left. So you have the healthcare delivery, where patients need health services. Healthcare provider and interdisciplinary healthcare providers are the ones who provide these health services, and this leads to outcomes. Each one of these boxes represents a different data stream and yields health data. These health data can be supplemented by other sources of health data that can come from various levels of organizations across Canada. And these essentially undergo a complex data integration process. This includes minimum data standards, as well as conversion, transformation, and loading of data that goes from messy to clean. And once it's clean, it gets fed through a data pipeline for health workforce planning and gets loaded into a pan-Canadian health data repository. And this is this wonderful big data network that is interoperable with other data pipeline for health that can also feed into it and be linked together. And from here, this data is accessible in real time through a user interface. The user interface can be for the purpose of health workforce planning or for any other purposes that different stakeholders need the data for. This helps to inform decision makers to improve and sustain healthcare delivery. So there's the loop. And ultimately, I'm not sure how long I have left, but so this is the first publicly available modern data architecture for health workforce planning in Canada. Many parts of this architecture are actually already underway, but are occurring in silos. And adopting such an architecture will allow for real-time data analytics for decision makers to improve healthcare and consistent outcomes as per the quintuple aim. Thank you very much.
Thanks very much, Dax. So next up we have Physician Resources Integrated Model, Prime Dashboard and Interactive Tool for Physician Workforce Planning in Ontario, Canada. And it's Yasmin, I think.
Thank you for the opportunity to share our work on an interactive dashboard for physician workforce planning in Ontario, Canada. The Physician Resources Integrated Model, or PRIME, is a tool that can help frame questions, define needs, assess capacity and map infrastructure, using leading practices in population needs-based planning and innovative machine learning methods. PRIME mobilizes the best available data related to population health, health services utilization, and the physician workforce. The model estimates the physician workforce that is required to meet the unique needs of patients, based on their demographic and epidemiological profiles, and an appropriate level of service. An interactive dashboard format allows users to select the type of analysis, physician specialty, and target level of service, and presents tabular and map-based outputs that are also downloadable in PDF format. The poster presents an overview of the interactive dashboard and a sample output using the specialty of cardiology in the fiscal year 2021. In this example, Southwestern Ontario requires 27 additional physicians to meet the estimated need for cardiology services. This gap should be interpreted as an indicator signaling a potential problem that needs to be discussed within a holistic, multifactorial policy framework. The PRIME model and interactive dashboard respond to a need for tools that leverage data analysis and visualization to support planning. The Ontario Medical Association recognizes that workforce planning is pivotal to improving the efficiency and resilience of the healthcare system, and through PRIME, is working to support and strengthen the culture of planning in Ontario.
Okay, great. Thanks very much. Really interesting to think about that in the context.
Thank you for the opportunity.
Of the presentations we had earlier from Sarah and who was the person online? Cynthia. And also as somebody from the mental health sector, to see all this physician data kind of makes me want to cry, but it's great to see it. So Okay, so next up we have quantifying nurse workload and care quality with simulation, future health, human resources, decision support tools.
Thank you. Hi, everyone. I'm Sue Bookie-Bassett, and I'm presenting on behalf of our team. This is a simulation model that has been developed in combination with a nurse engineering ergonomics team. This data that we're showing here is just one example of how we've been able to use a simulation approach to quantify nursing workload. And what we are showing on this slide is some of our data that we collected during the COVID pandemic. And what we've done in the work in developing the model is really develop a simulation of the day in the life of a nurse, if you like, in terms of all of the things that they do in terms of providing care during a 12-hour shift. This uses a variety of methodologies, including time and motion studies, as well as some surveys to look at missed care. And what you can see in the middle of the poster is really a stack of bars, which represent the different activities that nurses engage in during their 12-hour shift. What we found is that nurses who are working 12-hour shifts have almost 14 hours of care to provide. And so in a 12-hour shift, they're either going home at the end of the day, missing care, or they have to stay back behind to complete the tasks. And so we know that nurses are overworked, as we've seen through many, many studies over the last several decades. But few organizations actually do any kind of quantification or measurement of workload. And what we've developed is a simulation that allows us to quantify workload, as well as quantify the outcomes in terms of quality of care, such as missed care, the amount of time nurses are spending during a workday providing care, so direct care, indirect care, as well as to indicate what type of care is being missed. And the far right graph shows you just an example of when nurses care for more than one COVID positive patient, they actually end up spending less time providing direct care, but more time spent during donning and doffing. And so what we saw in our simulation was that nurses might end up spending up to 6 hours of time donning and doffing PPE if they have 5 COVID positive patients. So it's an example to show what we can model in terms of potential workload outcomes, care quality outcomes. We've extended this work into a couple of other settings now, and really looking at this as a potential decision support tool in terms of rethinking how healthcare providers can do their work and how we might redesign the work environment for them to improve workload and or improve better patient outcomes in terms of the quality care that we would like to provide. Thank you.
Thanks very much, Sue. I love that magical thinking part of the graph. That was definitely caught my attention. Okay, so next up we have a novel and practical care process framework to inform model of care development with Donna Meadows.
And I'm right here.
Oh, come on up, Donna. Do you want to, yeah, or wherever you're more comfortable.
I think I'm set up here.
Okay, good,
I
good.
won't have my notes up there. And thank you so much. I'm presenting on behalf of my co-authors. This care process framework is, we believe it's very innovative. We've been working on it and testing it for the last 8 years, and we're continuing to test it. I know Joanne McLaren, my colleague, is on the call right now. But we first tested in 5 communities on Vancouver Island and looking at primary and community integrated care. And it was, it came from a provincial initiative, and we were really doing more of a quality improvement, I think, at the time. But our purpose for doing, for testing was seeing if the care process was actually reproducible, even though the care needs in each of the communities were very different. We had the opportunity to actually publish this year. So Healthcare Management Forum carried it July 2023, and we put the QR code up there if you're interested in having a look at the article. But so the original framework was used to develop learning and performance support strategies. So everyone's heard like the cognitive task analysis in the old days, and this was now called a rapid task analysis. And really it was an engagement with all our key partners in the community. And what the process, we were able to tease out a lot of the tacit knowledge that clinicians have. So part of the engagement is sitting down and engaging with them and asking them what type of care activities they're doing for their population. And then we map out the competencies that you need to actually perform those. And I know this morning we heard a little bit about the taskification and the skill sets diminishing potentially with all the additional support roles. And what we found in our study was actually the opposite. What we found was that our highly skilled clinicians were not actually able to do their optimization of scope. They were running around doing all kinds of other things. And what we heard was over and over and over, I never get to practice what I learned in school. And so what was interesting and unique is this care process actually, you lay out the journey of a typical client. And that's the unique part, not the mapping, because a lot of folks have mapped out professions and this and that and who can do what. That's not the unique part of this. The care process actually follows the journey of the client. And what we didn't know when we first started out was that that can change, and you can actually have different clinicians at different parts of the stage. And that was a revolution, really. So when we started to think about that, we had the wrong clinicians doing the wrong thing at the wrong part. And we were like, wait a minute, if we might have the right team composition, but we don't have them doing the right skills. So right now we're working in mental health, we're working with urgent primary cares, we're working in different areas. And what we're finding is the same exact thing that's happening. We're starting to add support workers into, let's say, mental health substance use with our highest vulnerable populations, but they're doing medication administration, they're doing all these high risky activities. And our clinicians who were actually have the skills to do medication admin and assessments and intaking are not doing those things. So we actually might have the right team composition, but we're doing the wrong skills. So super interesting. I think that there's great opportunities where we've got a bunch of other areas and we're still learning. Thank you.
Thanks so much. I appreciate that. It reminds me of some of the stepped care work that I've been doing in my new role as well. Okay, and last up, and we'll just have a couple of minutes for questions. So if you have one, get it ready. The Health Worker Burnout Toolkit. Some work.
Hello, everyone. Our poster draws on a study that examines burnout among healthcare workers. Our goal is to understand the factors that may facilitate or hinder burnout among Canada's health workers. Our research team has developed a multi-level intersectional inventory of high-quality resources that target system, organization, team, and individual levels. We curated resources that include topics such as burnout, workload management, conflict, bullying and harassment, discrimination and bias, and stigma and disclosure. The link for the toolkit is included on the poster, so feel free to browse and share widely. We're happy to receive any feedback you have to offer. We're currently working with 4 partner organizations to help them address the various challenges they're experiencing. Each site has completed or will be completing an online survey followed by focus groups to determine the unique needs of each organization. Based on our preliminary findings, burnout, presenteeism, and feeling disconnected and isolated have surfaced as common themes across 2 of our sites. Choosing an intervention can be challenging when there are so many options and limited capacity. To date, we have discovered that resources of interest are those needed to connect staff and foster a shared sense of purpose in work. Starting small is important, and doing something is better than doing nothing. Assessing organizational readiness is a valuable process to engage in for the mobilization of wellness toolkits. Locating a champion or team of individuals within an organization who are ready and committed to improving the work culture is extremely powerful in working towards meaningful dialogue and ultimately a positive outcome for all health workers.
Okay, great. Thank you so much. Any questions from the audience? A big round of applause. Are there any online questions?
No, but I'm itching to ask a question.
Okay, go ahead, Gayle.
Dax and Sarah, when I saw your graphic, I should say, it's super impressive and it looks like it's got it all. So it made me think about places like ICES, Pop Data BC, Manitoba Center for Health Policy, who have spent years pulling together the resources that they have. What is it that sort of initiative that you've envisioned would add to what they have in terms of data?
Thanks for your question, Gayle. So what we envision is a data architecture, and it outlines how data should flow around the system. And it also helps us understand where health data stewards like ICES and Pop Data BC fit in. So, and how they can fit in. If data are interoperable and flow through pipelines having been integrated in a way that is standardized into a health data repository that then connects with other data pipelines, such as those from ICES, then they can be in turn fed back into the system. And that is not happening right now. So the feedback part, the health data application for planning is not happening. The interoperable integration is not happening. There's a lot of data in silos. And what we envision, this circular process, is something that is new, and we envision that it could actually really revolutionize the way that we deliver healthcare by allowing us to learn about what works and what doesn't.
And if I can take 30 seconds just to add on, because that's a great question. And you said that the figure has it all. So we're actually developing 3 figures that go into much more details on that main overall figure, because there's a lot more details that go into it. And part of those details is, how do you make this data interoperable, and what kind of processes and tools do you use to do that? And so if the silos, or if the work that's happening in BC and anywhere else follows this common pathway, then the data is going to be interoperable across Canada. And so often we say, you know, the Canada is the land of perpetual pilot projects. And, you know, it's interesting because if we have a common vision, and if people follow the same, you know, pathways and use the same tools, they can continue to work in silos, but everything is going to work together at the end. So that's part of what, like, why we need that overarching data architecture to pull it all together.
It reminded me of what you talked about from Colorado, that you have multiple layers of data, but you have to bring them together to get those needs-based planning estimates. And the question I have, but we won't talk about it today, but I'd love people's thought, like, how much is it going to cost to do that? Like, is this realistic? How do you cost? What's the policy proposal beyond the schema, like the vision for it? But like, what does this actually cost to do? Anyways, I'm going to turn it over now to Gayle, who's going to take us through the 3rd round. I feel like we should have a boxing ring bell, round 3. Wake up, everyone. All right, round 3 starts with Isabelle Giroux, who is online.
Bonjour, hello, I'm Isabelle Giroux, dietitian and professor at the University of Ottawa and lead of the Dietetics Team Primary Care project team. We're working on interprofessional team-based primary care synchronous virtual simulation modules for dietetic education. There's an increased need for educating dietitians about competencies required to work in interdisciplinary team-based primary care settings to help meet healthcare demands of Canadians. The objective of the project is to develop, implement, and evaluate an innovative interprofessional education toolkit featuring asynchronous virtual simulation-based learning modules for pre- and post-licensure dietitians to strengthen key practice competencies for team-based primary care settings in Canada. In Phase 1, we designed the online toolkit. In Phase 2, we developed the modules. We are now testing the modules. Phase 3 will be the dissemination and knowledge translation. The project will allow development of and access to a free online interprofessional team-based educational toolkit featuring 6 synchronous virtual simulation-based learning modules, 3 in French and 3 in English, designed to enhance key practice competencies for dietitians for Canada team-based primary care settings. This project is part of Team Primary Care Training for Transformation. Team Primary Care is an interprofessional initiative of the Foundation for Advancing Family Medicine. It is co-led by the College of Family Physicians of Canada and the Canadian Health Workforce Network in partnership with over 65 health professional and educational organizations across Canada. This project is funded by the Government of Canada's Sectorial Workforce Solutions Program. Thank you very much. Merci beaucoup.
Okay, that was very comprehensive and game-based theory included. The next one is around exploring gender differences in family doctor careers.
Hello, I'm Laura Jefferson from the University of York, and I'll be talking about a research study which we conducted as part of a rapid health policy research programme. As part of this, we undertook a mixed method study which explored factors affecting the decisions to take on partner roles in UK general practice. So in the UK, GPs or family doctors can work in either salaried roles where they're employed by a practice, or as GP partners where they own part of the business. Despite women now forming the majority of UK GPs, they actually only make up 41% of GP partners, and it's expected that this explains a large proportion of the gender pay gap in general practice, which is one of the highest of any profession. We undertook a number of different methods which are outlined on the poster, and particularly interesting were some of the novel methods around social media analysis and asynchronous online focus groups, which I'd be happy to discuss in some more detail if you get in touch. We conducted a thematic analysis and the results are presented in the diagram, which outline barriers to career progression at a number of different levels, including national level factors, organisational and individual level factors. There are gender differences across these, and these are denoted below and also asterisked in the large diagram. But there were also key factors that impacted both men and women GPs in their choices. These included flexibility of working hours, the relative attractiveness of other roles, wider political context and workload pressures, and finding the right practice. Further details can be found in our published paper if you follow the DOI. Thank you.
All right, next we have psychological health and safety.
Psychological health and safety of interprofessional primary care teams is an issue of growing concern in light of rising burnout and attrition rates. Health workers in training and in practice are expected to practice collaboratively, but they have not been taught how to work together in teams.
We developed an online searchable toolkit of resources to address the neglected issue of psychological health and safety of interprofessional primary care teams and training programs.
To collect and curate resources, we used a systematic environmental scan methodology targeting academic and gray literature. Resources were thematically coded and clustered according to 7 of the 15 psychosocial factors within Canada's national standard for psychological health and safety in the workplace.
The toolkit has 122 resources comprising a multi-level categorization addressing team, system, organization, and individual level interventions to enhance competencies of primary care practitioners to work more collaboratively within interprofessional team-based environments. We also wanted to integrate psychological health and safety competencies into pre-licensure or registration training.
Preliminary insights include a need for bilingual resources or resources published in French, that early resources have not focused on primary care settings, and few focus on interprofessional teamwork or on preparing future professionals for interprofessional collaboration, that team and training resources targeting individuals are more prominent than those targeting the team or system levels, but few focus on the interface of individuals within teams, and system-level interventions also neglect a focus on primary care team and training relevant circumstances.
We are currently working with interprofessional primary care teams and training programs across Canada to implement, evaluate, and refine the toolkit.
Thank you, Sophie and Melissa. Okay, now we're going to have super rapid fire. 3 presentations by the Canadian Health Workforce Network, starting with the micro program.
Great, so that is me. So hopefully everyone can hear online. So the micro program is a program that was developed in partnership with the Canadian Health Workforce Network and the University of Ottawa Faculty of Social Science. It is the only fully bilingual asynchronous microprogram in health workforce studies. And it contains 2 courses, again, offered asynchronously, fully in English, fully in French, and all of the English resources have been translated into French, which let's just say was not inexpensive. There is Introduction to Health Occupations in Canada, which really maps onto the next poster, which is the textbook. So I'll defer to that. The course Introduction to Health Workforce Studies, Planning, Policy, and Management is a course that's itemized into 3 different modules. So 4 sessions on planning, 4 on policy, and 4 on management. And that's very much focused at an international level. So anybody could take that. Because it is at an Ontario-based university, any Ontario graduate student can take the course through their university, essentially for free because they've already paid their tuition fee. Anybody who wants to take the course outside of being an Ontario graduate student can do that through the Professional Development Institute at the University of Ottawa. And featured here and on our website are recent graduates from the program that have come across Ontario. So 5 graduates. There are more students that have taken the program, the 2 different courses, but these are the 5 students that have taken the course, and we just started last summer. There are also graduates can co-publish the infographic assignment that they have in their course. So their assignment includes different quizzes, policy brief, and an infographic based on their policy brief. And 2 students co-publish those with partner organizations with the Canadian Health Workforce Network, the Canadian Family Practice Nurses Association, and the WeRPN. The program is also designated as a health leadership specialty with the Canadian College of Health Leaders, and that is something that you can earn CHE credit. And that's it. Thank you.
Hello everyone. Imagine a tool where you as researchers can get access to every published and great literature written about the health workforce or containing health workforce information from the year 2000 to now. This is what the CHWN library is. The CHWN library is the one-stop hub for all things health workforce. It contains a variety of subjects pertaining to the multiple healthcare sectors, with the aim of advancing, aiding, and creating conversation on innovative approaches in the field. So how does the library actually work? Well, since it's a hub designed by and for health workforce researchers, the library optimizes user experience through its dual search function. The dual search function is the presence of a basic an advanced search tool that allows researchers, based on their needs, to quickly or more in-depth filter out information that pertains to their research. With the basic search function, you as the researcher can only use the author, healthcare worker, or subject as the main search themes and get articles relating to your research. However, for researchers with a more enhanced strategy, so let's say you want a specific methodology or articles related to a specific geographical location, you can try out the advanced functions. The advanced function allows you to be as specific as you want, not only about the things in the basic function, but more things like geographical location, title, year, and research methodology. Once this is done, this tool will ensure that health workforce researchers have a research repository that serves their needs and puts them first. Thank you, everyone.
The Canadian Health Workforce Network is excited to announce the upcoming release of their updated Introduction to Health Occupations in Canada textbook. The text includes 2 new chapters, now including massage therapists and social workers. This open access, peer-reviewed text takes a deep dive into 23 Canadian healthcare professions. Each chapter contains an overview of 5 main areas of interest. These include the history and evolution of the profession's educational and training requirements, including the number and spread of educational institutions, the regulation variation throughout Canadian provinces and territories, their demographic composition, including gender, age, and distribution, and the highlighted profession's scope of practice and roles. A special feature of the updated text is the new inclusion of the consideration of the impact of COVID-19 on the Canadian health workforce. The aim of the Introduction to Health Occupations in Canada textbook is to provide insight into the importance and ever-evolving roles of Canadian healthcare professionals.
All right. Well, that was a ton of information and hours of work presented in 1 hour. There was a question online about what's the easiest way to access these posters?
Yes, so that I can answer. We do have all of the posters in a Dropbox, and so we can provide a link to that, but we're going to polish everything off and upload them with a link to the conference website on the Canadian Health Workforce Network webpage. So where you went to get information, to get the link to register, there will be a link there, but they'll probably all be tidied up on the Dropbox. So thanks for asking.
Okay, any questions in the room here? As it gets dark around us, right? And so does the energy level. There's one question online wondering about the course and if it's available for this upcoming winter semester.
So the course that's available for this winter semester is the Introduction to Health Occupations in Canada, because we're just finishing off the Introduction to Health Workforce Studies. And in the spring term, May and June, will be a condensed, because it's a 12-module course, so there'll be 2 modules per week for a 6-week course in May and June. So that will be the Introduction to Health Workforce Studies.
And now 2 questions about the book. Is it available online now, or is there a release date? And how could it be accessed?
It is finished. It has not been translated yet into French, and so we do that as well. Everything is limited by our human resources, so I don't want to promise that it will be available next week, but it'll definitely be available before the Christmas break. Oh, and where you would access that is online at the Canadian Health Workforce Network under our resources page, and then there is the intro text will be there.
Okay, that's the last of our questions. So I think that's a wrap for day 1. Big round of applause.
Thank you.